Minister, Dr. Zweli Mkhize, the Deputy Minister, Dr. Joe Pasha, Dr. Angelique Gutier, the Chairperson of SAMO, Dr. Mvuyisi Mzukwa, the Vice Chairperson of SAMO board members that are present here, leaders in the healthcare industry, friends and colleagues, and the SAMO staff that may be here. A warm welcome to each and every one of you. My name, those who do not know me, is Dr. Vusumuzi Nhlapo, currently the General Manager for SAMA, and I will be directing the proceedings this evening for this important event. Once again, thank you all for coming, those that are here in person, as well as the colleagues that are joining us virtually. This is an important event as we try to do our best to keep the novel coronavirus at bay. The President's announcement on Sunday night about a national disaster in relation to the coronavirus has set all kinds of activities into motion this week. And I think colleagues would be aware of some of those activities. But in fact, what is important to note is that the Department of Health, together with the National Institute of Communicable Diseases, were moving well ahead of any of these activities, as the threat of COVID-19 loomed large for South Africa. By the time we got to our first case in South Africa on the 5th of March, the Department of Health had been preparing for some time, and for that, we are deeply grateful. We had testing protocols, guidelines, hotlines at the NICD, and various other mechanisms at our disposal for the identification of cases. We therefore had a head start in some respects. We are aware of the fact that in some other areas, there remains a lot of work to be done, hence the importance of this engagement tonight. As we move more into the practical and very real aspects of this outbreak, many more questions have emerged. And in the last 3 weeks, SAMA and the leadership of SAMA has interacted with various stakeholders, and in particular with the Minister of Health in preparing our doctors for this. So as the questions emerges, we thought it important that we invite the Minister to address some of the concerns that doctors would have. And this is both doctors in the public as well as in the private sector. From the very beginning, the Honorable Minister has been involved, engaged, and committed to the fight. And we're very fortunate to have him here tonight. We're grateful of the leadership that he has provided up to this point, and we value the opportunity to interact with him as he manages some of the questions that colleagues have at this point in time. We therefore take the fight against COVID very seriously, and this is an important opportunity for our colleagues, both online and here present, to interact with the Minister, the questions that are concerning you, the bread and butter issues that doctors are dealing with, and maybe issues relating to the preparedness as a country. Thank you once again, Minister. In terms of the proceedings, as I indicated, we have about 450 colleagues that are joining us online, and we've got colleagues over here. So the first thing that we'll do, I'll call upon Dr. Angelique Gutier, who is the chairperson of SAMA, to have some opening remarks and introduce the Minister. The Minister will then have 20-30 minutes to do a presentation to the audience, after which we will then take questions and answers that you may have. At the end of that process, I'll call upon Dr. Mzukwa, our Vice Chairperson, to do the vote of thanks, and that will be the end of the proceedings here. We will then take the Minister through for a few questions, with the media at the end of that proceeding. And once again, I'd like to thank you for being here, and I would now like to call upon Dr. Gutier to have some opening remarks.
Thank you. Thank you for everyone that's here tonight. And thank you to everyone out there that even if you're not a SAMA member, you are most welcome to attend this very, very important meeting. Tonight is a meeting actually for us as doctors. It's a meeting where we need to come up with answers. Maybe we think that Minister's got all the answers. I doubt whether he will have all the answers. This is a new disease in our country. There is no answers writing in black and white so that we can follow this process. We learn from the other countries, but we are a unique country in South Africa. We will have our own unique challenges. Although we can learn from other countries, we will still need to make it tailor-made for us. Also, we need to support the Minister and his whole presidency in this, Dr. Joe Patla and NICD. We need to strengthen their hands in also coming up with solutions, not only questions. And we should not only sit here and vent tonight. We must try to come up with workable ideas as to make this country see the light in what is going to lie ahead of us. We are still not in the, as people like to call it, the eye of the storm. We are moving into that. We're not there yet. It's not going to be easy next 3-4 months, right? It's going to be difficult. We all need to bring our side. We all need to work together. We need to put silos behind us. This is not anymore a place for I'm private and you are public sector and I'm from this office and you are from that office and I know more than you know. I'm sorry, we are all in this as a collective and we have to strengthen the hand of our leaders and our president as well as all the ministers involved in this. We have enough brain power among all of us to be able to sort this in a much better way than we are currently doing it. Please, my pledge, my pledge is that SAMA will definitely try its best to bring our members that is everywhere. From the Minister, you can mention a clinic in the rural setup and there will be a SAMA member. We would pledge to be your ears and to pimp on where it's going wrong, to make sure that we understand. And I'm so glad that tonight we can actually talk more in a medical language, as this last 3-4 weeks we are trying to get the message out to the broader public in the most easiest way. That is not always the correct medical terms that we use. But there's another population out there that needs to hear the message. And again, I thank every one of you here. Minister, you are especially welcome here because without you, we cannot do this. Joe, thank you again for being here. I just need to tell you that these two gentlemen was part of the group that is making it possible tonight to have a SAMA. They were part of the group that transformed the old MASA into the SAMA. So for that as well, we thank you. Thank you, Minister.
Thank you, Angelique, the chairperson of SAMA, the Deputy Minister, Dr. Joe Patla, the Deputy Chair, General Manager, and other members of SAMA, colleagues in SAMA and colleagues in the medical and related professions. Thank you very much for this evening. This evening I came for a conversation. It's a conversation in which I hope to leave here with a lot of suggestions and proposals that will make it easier for us to deal with this challenge of the COVID-19. Our approach tonight is that we have the good fortune of talking to the people who will see the presentation of the coronavirus before anyone else does. And it's up to their judgment that we are able to actually even suspect and therefore test and then diagnose and report that anyone has got this virus. We are today exactly 14 days since the first patient was identified outside Pietermaritzburg in Hilton. At that time, we had been talking coronavirus, but we had not seen a patient inside our borders. And at that time, we had reported 2 patients outside South Africa who had been infected, and that was out of the Diamond Princess cruise off the coast of Yokohama, whom we were subsequently informed that they had actually improved and they were expected to be back any time to South Africa. Out of a crew of 12, 10 of whom were going to stay on quarantine. At the same time, we had also had a story of one South African who had been found to have been positive in South Korea. It has since been rigorously investigated, and we now have confirmation that in fact that was fake news. The gentleman reported a positive test which he hadn't had. So when he was actually asked to divulge the institution that had tested him, he could not do so, and then he ultimately confessed that it was not true. So that means that outside South Africa, at that time we only had 2 people. Even those who had been in Wuhan, and we subsequently got them back, and those who had come from China, we never actually had 1 person infected from China. Those who came from Wuhan were actually put up in Limpopo. The first tests that were done on them came back all negative last 3 days ago. So the real issue now is that coronavirus arrived in South Africa 14 days ago. We panicked with 1 patient. I can tell you that we got even more surprised to see the rapid spread of the rapid increase, because 2 days later we were actually at 3, and then it started moving in that direction. As up to last night at 8 o'clock, when we do a cutoff of the reconciliation for the day before we announced today, then of course we had 150. And we are quite certain that by tomorrow we would have gone much higher, probably just beyond 200. So the reality for us is that we need to be working together to deal with this issue. And as you will be aware as well, the President has gone all out to call for a lot of stringent measures, declaring the state of national disaster, and also excuse me, and also got a lot of stakeholders, leaders to come together and unite in an effort to fight this virus. The National Command Council has been formed of the President and ministers, and we've been out there. President has met with various political leaders, and the different opposition parties have come unanimously to say this is not time for politics, this is time to fight together, which we appreciate. We appreciate the initiative of the President. Today we met the leaders of the largest of the church groups in South Africa, mosques and synagogues, chief rabbi and the top imams and bishops and archbishops. And all of them came out saying they really are going to do everything in their power to limit the spread of the infection by reducing, in fact, canceling most of their huge gatherings, and then, of course, reducing the numbers of people who attend per service. I like their approach where they say turn your home into a church, turn your home into a mosque, turn your home into a synagogue. Don't stop the prayer, but everyone must pray at home, so that the numbers that have to congregate together were very, very limited. In that process, they also went up to say to those who believed that they would need to come together to pray, because that's what would actually help them. But they said that we need to combine the two, that whilst you pray, but you have to take the necessary precautions of good hygiene, social distance, and so on. And I loved one bishop said, one said there was someone who was praying and said to them, no infection, COVID infection shall prosper, saying to the one gentleman. And then, of course, the bishop was saying they need to be informed. And he quoted the verse that don't put your God to test. The reality is that they have enough biblical basis to motivate for supporting the call by the president. I therefore want to say that from where we sit, we've met taxi organizations, we've met various other leaders, there'll be other traditional leaders and so on, traditional healers who will be met as we move on, individually and collectively. All of those have been very supportive, and therefore the issue is how can we make sure everybody spreads the message. When we are here meeting with SAMA, we believe we're actually meeting the real foot soldiers, the fighters in the forefront, who are the ones who will actually help us to locate the presence, the trend, the manifestation, and different aspects of this infection. So we have seen that the various provinces are slowly showing up. At the moment, Gauteng is the one that's got the largest at 75. We have KwaZulu-Natal 23, Limpopo 1, Mpumalanga 5, Western Cape 46, and of course these numbers are going to increase because tomorrow we will be reporting about Free State as well. The numbers are actually on the rise. But we've also seen the behavior of the infection. Today, Italy has 35,000 people infected, and the mortality rate is almost as high as China, who are at 80,000 of patients. But China, at 80,000, they've actually almost tapered off, and the numbers have not been showing a lot of increase. They've seen a lot of recoveries, and at this point, over 60,000 people have recovered. And it's important for us to look, in fact, it's much more than that. I think it's getting close to above 60,000. But it's important for us to say, we are not going to be different as South Africans. We are going to have to face up to a number of lessons from various countries, but at the same time, we are unique. We should actually understand that we can behave in a way that can change the course of this infection. So with both of those, it means whilst we have to be alert and learn from what the others have done, we also need to make sure that we make our own history as South Africa. So with that, we have had a discussion. 3 days ago, we met a number of clinicians, pulmonologists, intensive care specialists, infectious disease specialists, virologists, epidemiologists, a whole group of professionals who are all involved in this whole fight. And went through this whole discussion. The idea which we thought was important was to be able to discuss how do we ensure that amongst ourselves we coordinate our effort. How do we make sure that those who are involved in the clinical management of all the cases are able to coordinate, are able to talk together, and we are able to almost standardize certain approaches in the management so that we are able to say, anyone who needs assistance, this is the kind of approach that we are utilizing. And it's important for us to be able to do that because we're not only just treating individual patients, but the public outside is also watching how we're managing. And people mustn't kind of feel that this is what was done, that was what was done on someone else. Therefore, they must then not start having a sense that someone knows what they're doing, the others don't. And this is actually a bigger problem in the days of fake news. So we had quite an interesting discussion, and therefore we even agreed at that point that we are going to be, we're in the process now of forming a ministerial advisory committee on the issue of the outbreak, which will coordinate a lot of efforts. And we were then saying that on the one side we need to see a clinicians society that will be discussing various approaches and looking at the various lessons from all over the world on how to deal with this virus, as it were. Lots of speculation out there, and people have spoken about antiviral treatment, interferon, chloroquine, etc. But we are aware that there's a whole lot of trials that are going on at the same time, including the issues of vaccine, which we need to upfront say that at the moment there's no vaccine available, and we make this just not so much for the doctors because they all know this, but because in the public arena, now and again you get someone who stands up and say, well, there's a vaccine somewhere, why don't you get the vaccine? The Professor Helen Rees is part of the WHO team that is actually leading South African effort in the creation of that on the vaccines. And so in the next 18 months, we expect something should come through by way of the vaccine, but there will be participation of South Africa by around June when this trial actually takes off. So we are asking that on the clinician side, there should be some discussion which allows us to be able to say these are kind of standardized protocols which we can all utilize. Then, of course, there's a space for debate. There are lots of issues for debate, very interesting issues for debate, as it were. But then the second group that we thought we need to focus on would be the group that deals with the pathologists, virologists, and those and laboratories, so that there's a coordination across that sector. Today, I had the opportunity to talk to CEOs of most of the top private laboratories. On Saturday, I also had a similar discussion where we're talking about how to make sure that we treat our testing capabilities as just one service, one institution, where everybody will test and they standardize their approach, they talk to one another. We even said they must have their own chat group so that if there's anything you're not sure, talk to the others. At this point, it's important that they coordinate, they are standardize their approach, that they also talk to each other so that when there are queries on the results that they are getting and the issues around approaching what technology to use and so on, there's quite a lot of stuff that comes up which is interesting, as it were, particularly when there are interpretation of results. We've had an instance where you've got someone who comes up positive, and then a few days, a day after that, done by one private lab, positive, and say, okay, let's validate in the public NHLS laboratories, it comes out negative. A whole debate that has come up. And in fact, ultimately the consensus was that judging from the way that the disease is manifesting itself, it needs to be accepted that they caught this particular patient at the tail end of a viral shedding period, and therefore now when they came in later, the patient was already turning negative. This is an interesting angle because if you look around, it's not clear what's happening to the younger people, but it looks like most of the younger people may well be having the virus and might be shedding the virus for shorter periods, but of course that's subject for research. So you will have your own experience where you are, where you can guide us in terms of what you are finding. So that would be the one group that is looking at this issue. Then of course the other aspect, we said that you need the other group that will actually look at dealing with mitigation issues, prevention issues, the epidemiological trends and various observations that are guiding us in terms of the development of this entire problem of the outbreak. We have also asked that the provincial leadership need to break down and organize themselves according to districts where public-private must be able to relate look at what capacity is there, how many practitioners are there, public, private, how many facilities are there, how many beds are there, what level of care is possible in a district, so that it is not difficult to coordinate. We've now come together to work with the private hospitals, and we've said at a certain point when we need extra beds, and the hospital was the public sector initially identified a few hospitals. As soon as we saw that the threat was rising, we've actually said increase the beds. There must now be decentralized beds which are created on a city-to-city or town-to-town basis, so that we must have more space to be able to absorb a number of the people. At the same time, we're looking at possibilities of assisting in quarantines. It's easy right now when we're dealing with quarantine, particularly when the people have been traveling to Europe and all over. They're actually middle class who have got well demarcated areas. It's easy to control movement of people into the area. Some of the areas, the level of congestion will not allow, the numbers of people that will not allow easy isolation or easy quarantine. So it means, therefore, we need to actually start providing situations where people can actually be moved off their normal settlements into quarantine areas. All of these are things that we are looking at, as it were. On the other hand, we've also started negotiating with various hotels, so that around the airports, international airports, we are able to provide hotels to be able to draw in people who we believe need to be quarantined. Instead of allowing them into the country, we quarantine them around the hotels, and therefore we need to work out protocols around those issues. So generally, in terms of the broad thrust of managing this infection, I think we're more or less moving together. We're looking at how to increase the testing capabilities so that we can test as many people as possible. We've been talking about it, that at this point we've just probably gone about 1,200 tests, and this 150 comes from that number. But we now need to start being ready to test a couple of thousands per day. Both those who are symptomatic, as the guidelines say, but then we believe that now this is time to actually have targeted surveillance, where we go to areas where we think there might be risk and be able to assist there. And secondly, we need to also be able to increase capability to have what we call drive-by testing and mobile testing capacity, as it were. All of these issues are important as we deal with this. We have also asked that our team must now work very closely on looking at recoveries. In this case, for example, the one person that I said turned negative is the vet student who actually created a huge excitement in the university community. That has been the interpretation. But the one in Pietermaritzburg was the second patient to be identified, was asymptomatic when they took her to hospital. And at the end of the day, has had to be discharged, but also had already tested negative. So we now want to start recording those recoveries, as it were. So far, we don't have any record of any death, which is very, very important. Now, the real challenges are how do we manage a lot of issues. When we talk about communities out there, to send information and get education to community to be educated is very, very important. So we are going to need to work together, that every general practitioner, every doctor, every private practice should actually be part of a network where we are able to share leaflets, share information, so that we are able to actually send this information as widely as possible to the community. There are challenges of supplies, the shortage of barrier protection clothes, gloves, masks, and so on. There's a risk of price hikes, but there's also the fact that the whole world is looking for the same stuff that we need ourselves. And for that reason, we need to then talk about how do we use judiciously those kinds of equipment and protective gear that we need, when in fact the whole world is going to be in need. So we need to then start talking about at which levels do you, in the isolation ward is clear. You need protective gear and all the whole kit, and everyone is clear about that. But at which point are we starting to look at or on the public facilities in the private sector, that when you deal with a large number of patients, you actually have to get your staff to wear masks and so on. And we need to be talking about all of those issues. Or should we just confine it to the area where people are having only respiratory symptoms and so on? These are the things that we have now to start working on as we try to make the gowns and sort of make the masks and gloves available to the different levels. It's important as well because there are high pressure areas where there's lots of overcrowding and lots of patients, and all of this is something that we, at the moment, is easy to identify imported cases. But once you've got internal transmission, you can never know that this one is or this one is not, particularly as we move into the area, to the time of winter when the flus and colds are going to be increased. Now, the real issue has been that the first patient who was diagnosed by a doctor was pretty wise. Immediately, she was able to say to the patient, "You're going to quarantine. I'm taking a test on you." And look, the symptoms were not very bad, but that's what the doctor said. And as soon as the results came back, she went to quarantine herself. Now, there are going to be many of us who are going to then ask the question, how do we avoid ourselves being exposed so that you don't have to be quarantining yourself, or that, in fact, the patient may not immediately display the symptoms, and once it's gone, then you find that you could have been exposed. We're talking today with the MEC of Western Cape. She's completely well and very wise in her decision. There was a diplomatic corps that had convened, and therefore there was a whole discussion. And in the process, one of the consul generals actually was found to have been positive, and then of course it prejudiced everyone else. Now she has to go on quarantine. It's easy when you deal with it in an environment where you can identify a possible source of the infection. Imagine someone who then comes from Langa, takes a taxi, and gets from there into a train, and takes a long distance taxi from Cape Town all the way to Johannesburg, and then goes further to Limpopo and back. Now you want to ask them if they know who their contacts were. Now the challenge is that even if she can tell you where she was, she's really or he's really not able to know who was in the taxi, because half the time you don't know who's sitting next to you in a taxi. So those are the issues that we must now be conscious about. So when the steps we took to say, let's actually start putting the restrictions, is to actually reduce the possibility or the rate at which the COVID-19 virus will start spreading to affect people in the areas where we know are most vulnerable. And that's really what the issue is about. We're trying to flatten the curve, we're trying to delay the onset of the infection, but we are then saying we need to discuss the issues that relate to you. We would like to get your suggestions. What's the best way of dealing with this situation? Somebody will come to see the doctor, and then, do you remember every day who was there, how many people were there? It's very difficult. There's a typical example. We've just had, a few days ago, a doctor came from, I'll tell you about these two doctors. The first one came from, he had gone abroad, and then we're discussing this issue that most of our people are now getting infection from such countries as Italy and so on. And the doctors were sitting there and they said, "Oh, Dr. So you came from one of those countries." And then they agreed that he was going to go into quarantine. He quarantined himself and then decided, "You know what, I'm going to do a specimen." He did it and then came back positive. And that was quite nice because everyone took an immediate precaution, kind of. We now need to check if there was anyone who could have been affected. The other one was less fortunate because he came back well, asymptomatic, and then a little bit of upper respiratory tract infection. And all of a sudden he went around, he operated, he met with people and so on and so on. And all the way he went up to see his GP to say, "This thing is irritating me, can you just sort it out?" Just, "Okay, go test." And all of this was just open. All of a sudden now it was positive, and then we now have to go back to the hospital and say, "Okay, over these past so many days, you start finding a larger number of people who must now be pulled together. So these things are going to happen all to us every day, and you will not see it then. You will see it after it had happened. And those are the things that we must discuss. What are your suggestions, as it were? As we increase the testing, we hope that we should be able to get to a point where we target certain areas where we know, for example, that with the flus and colds that are coming, there are people who are going to be, because of the time of the year, are going to be coming up more and more with this. But how many of them do we know already could have been affected because of this phenomenon I was describing about people moving from taxi to car, to train and so on? So we need to actually target certain areas and do some kind of surveillance. There's a big debate that came up in that meeting of the clinicians as well between us and NICD. Others saying, no. The guidelines are you test the symptomatic. And you say, well, symptomatic, yes, but if you got me out there in the village, half the time I'll have the cough and a bit of a flu. I won't rush to go see a doctor, especially if I've got so many other worries to worry about, even transport fare and all of that. That becomes one of the challenges. Then it becomes an issue of someone will be infective and they don't know about it because they don't feel it's a very serious issue. We all know 80% of the people have got a mild or moderate disease, and most of them won't even get to see a doctor or won't even get to be admitted because of the mildness of the symptoms. So how do you deal with that? So we might need to do those kinds of spot checks, as it were, a surveillance kind of mechanism. So these are some of the things that we now need to be talking about amongst ourselves. So really, as we are sitting here, we are talking about what are your experiences, what are your suggestions. One of the things that's become a very interesting debate is the fact that if we went 4 or 5 weeks ago, the COVID-19 test was being done by public sector. And therefore, if any private sector had it, wanted to do it, would just simply screen for the other viruses and send the specimen to the public sector. Right now, private laboratories are doing lots of tests. In fact, 97% at least of the patients who have been diagnosed have actually come from private sector. I don't remember anyone that really came from a public hospital or a clinic. So the bulk of them have come from there. But there's a cost to it. So how do you deal with the cost? Because now people have come and said, okay, we're told that we need to try and get ourselves to test, but the cost of it might be inhibitive. So that means now we have to actually open up the testing a lot more wider than what we might be doing at the moment. So then it becomes a bit of a challenge, because if you are better, your symptoms are gone. Now, what's the problem? You want to be, you want to spend another 1,200 or 1,400 rand to check whether, but you're feeling better now, So a number of people may not go back to test because it's costly. That's why they got the first test. They were worried that time. Now they're no longer worried. So that's an issue that we have to look at. So what we have now been saying is that we need to ensure that there's a proper coordination, and we need to get assistance from the private doctors. One, when you test people, can you take as much details as possible at the first time so that we don't have a problem to follow up the patients? The tracking and tracing becomes a problem. In this yesterday's batch, there's a lot of instances where we say not enough information, not enough information, not enough information. It makes it difficult to go back. Secondly, we have said that sometimes when we get the test and we're going through validation and we're going through the processes, then the doctors get informed, and then the patient and the relative, they go on a whole Twitter campaign, and before we know it, people are saying, oh yeah, but the minister doesn't announce that there's a patient in such and such a place. That means they are actually not telling us the truth. Fake news becomes a big issue there. Whereas if we'd been able to coordinate this information, that would become it would be less of a problem. So what we are now asking for support on, we're going to get an NGO that's going to help us to do the mop-up. So after 14 days, we get the patients that are well and don't want to go back to the doctor, but we must then go and knock on their doors and say, you have 14 days, we want to take the last specimen, so that someone doesn't have to have the option of whether they go to the doctor or not and pay 1,200 because they don't want to pay that, they're well anyway. So we want to be doing that. Then we also need to make sure that there's a coordination, a strong coordination from NICD, National Department of Health, and provinces, broken down right up to district level. It's important because the real war right now, where we're having a weak element and we're trying to catch up with it, is tracing of contacts. At this point, they have recruited very close to 2,000 tracers, and therefore are coordinating the system so that we can ultimately be able to do this quickly. And we're trying to look at various mechanisms of how to improve the contact tracing. That is the angle that's going to help us. So high level of suspicion to the frontline doctors and nurses in the clinics and hospitals. At the same time, also the efficiency with which we're doing contact tracing. If we can lock those two and increase the numbers of tests that we do, we will then be able to actually match the spread, the rate at which the infection is moving. That is where we need to be. So whilst there are restrictions now, I think this week we won't be able to see much of a difference, but we must start seeing a bit of an impact, and the impact we will only get if we're all working together to try and say we do the same thing in the same way to everyone wherever we are. So that's why we came to talk to the doctors here to say, can SAMA partner with the department? Can SAMA work with us? Because the bulk of the people who are going to see the presentation of the infection are members of SAMA in private, are members of SAMA in the public sector. We need to say, what are your challenges, so that we must meet each other halfway to find a way to resolve those challenges, to improve your capacity to detect the infection, to prevent the infection from going from the patient to you, and to actually help to prevent the infection from going one patient to the next person. That is the fight that we must wage, and it's us at this level as professionals who must be very strong in this fight. When we were talking, I said to the to the colleagues that we are like in a battle. In the past few weeks, we were talking about preparations, are you ready, and so on. We passed that point. Whatever we were ready to do and what we're not ready to do, we're now in battle. We'll have to just make do with whatever we've got, and we must make sure we solve what we find. That's the one thing. Secondly, we wanted to get some information. How is the COVID virus? How is our enemy behaving? We found out now. This enemy is rapidly spreading. At the moment, it's imported cases, but that's the beginning to cross into a stable community where we're most vulnerable. So we now must mobilize our forces to target this. So I said we're in hard combat territory. This is combat time, hard combat time, which means it's going to be hard for all of us. But if we're focused and determined, we are going to be able to make an impact in the infection. I think that it's up to each and every one of us to say we want to make sure that we reduce the fatalities. We mustn't have the numbers just rising uncontrolled. That's number two. We want to make sure that we talk to our people such that we delay as much as possible a peak on this infection, so that the numbers that are there we can keep containing up until we can get to a point. Maybe by the time this thing becomes a reality, a big reality, we'll not be very far from the vaccine. Everyone knows our estimations. Our estimations in any community, 60 to 70% of the community will be affected by the virus. You can't hide that. So I said to the religious leaders, most of us were going to have this virus. South Africa, most of us will have this virus. It doesn't mean that then it's going to be a severe disease to all of us. It will be severe to the 20%. Let's make sure that at each and every time, the 20% is small, so that we don't have the strain of having to worry about opening up new ventilators and all of those things. And we're saying, for us to fight it that way, it means that we must therefore be aware that it is possible to turn this whole situation around. We don't want fatalities. We don't want a rapid spread of the infection. We don't want ever to have an infection where a health worker is affected. There should be any health worker infected here. We must just make sure of that. So how do we deal with that? That is really the point. So as of today, we do want to get a sense of your suggestions, proposals, and just know it that your suggestions are actually, you are actually shining a light in our blind spot. We're not there where you are. But we want to hear where you are and what you are seeing, because that's where the tire hits the road. That is where we need to then say, with those suggestions, you must know we'll have to change policies, guide everything to take to make sure that your detection, your prevention measures are helpful. Already, what we needed from the president and the government and the whole of society was that they need to unite behind us as we fight. Now they are united. We now need to get the society to be united behind us. Now they are united. What we now need to do is just to sharpen our vigilance and make sure that we do what we need to do and try as much as possible to innovate, but also to come up with suggestions so that we can change the cause of the infection. There are things that you will learn from South Africa that no other country will learn. No one has got 7 million people with who are HIV positive and many on antiretrovirals. No one has got as much tuberculosis as we have. No one has got the kind of inequality and spatial inequality and distribution of poverty to one part of the country and affluence on the one side. No one has got that. When we start talking lockdown, we're actually aware that there's a lockdown that can never work. You can't sit here and say you're going to go and do a lockdown in Guguletu. There's no lockdown in Guguletu. Guguletu is part of Cape Town. Therefore, you're actually talking about the entire ecosystem that is going to be affected. So nobody must start thinking, no, well, they'll put a lockdown in Anda, we will be fine. No, there won't be such, because we're one ecosystem. And it's simple. You could put a lockdown in a place, people will just walk over to where the food is, to where the workplace is, where the transport is, where the facilities are. No one is going to ever be locked down like that. So it's important for us to say it's going to be a combined sense of goodwill of all South Africans that we are going to be saying we want to help each other to get out of this problem. That is really how we need to face it. And so, as doctors and professionals, you must know you've got all the support from President Ramaphosa, you've got all the support from government and cabinet, you've got the support from political parties of various persuasions, you've got support from religious leaders, you've got support from communities, you've got support from the entire South African nation. They are saying, you are the soldiers on the ground. We are in the forefront, fight on. As you fight on, they'll be there to give you support so that the outbreak can be defeated. Let's flatten the curve. And you are going to give us suggestions, and we'll be here to listen. Thank you very much.
Thank you, Minister. As indicated, we will start with a few questions, in fact, 5 from the audience in here. And then the next round will be some that we've received during the day. We're receiving a lot of questions at the moment, from the participants online. So if I could open the floor for a number of questions. The Minister will make a note, and I believe the Deputy Minister will be keeping an eye on those as well. So
He will answer.
If I could take, that's 1, 2, 3, 4. Okay. Yes, Doc.
Thank you very much. I'm Dr. Tangi. Thanks, Minister, for the presentation. We have had quite a lot of concern regarding the, primary health care facilities in South Africa. We know that South Africa relies a lot on primary health care. And our primary health care, which includes state and private in this case, we talk about GPs, and state, we talk about state clinics. They really have no idea as to how to handle, this pandemic. Mainly because in the primary health care facilities, patients just walk in. And when they walk in, so when patients walk into the primary health care facility, most of the time, the staff do not know how to handle them. And worse of it, staff is not even in terms of protective gears. They do not have any, even the basic protection just to protect themselves. And we've realized that it becomes a serious threat to the community at large. Because the very same doctor who's just a GP alone there is going to be seeing, if the doctor is infected, will be seeing 30 or more patients that day, and in fact 30 or more patients that are coming from different areas or villages or townships. So we are concerned, and we would wish to recommend that in the fight of this COVID-19, that the Department of Health should look at strengthening the primary healthcare facilities, in as much as they are, running the testing and isolation and quarantine patients and tracing patients. But the primary healthcare facilities must be strengthened, and doctors must be afforded protective clothing, the personal protective equipment that is at least necessary to protect them. Because now, if we as the country are going to have doctors who are sick and sisters who are sick, then the whole healthcare system is going to collapse. So we request the strengthening of the primary healthcare, in as much as the tracing and the testing and the treatment of those that are positive are being taken care of. Thanks very much, Chair.
Thank you. Dr. Bali, you can grab the
opportunity. Thank you, Minister, for this opportunity. My greatest concern was when the President made his announcement on Sunday. I'm sure lots of GP practices across the country were flooded with questions about people who wanted to get tested. And we are struggling because of, trying to stick to the criteria, and we know that there is, at this point in time, limited capacity to test. We understand that the labs are overwhelmed with the testing. Is it possible to explain to the public what the criteria is for when you go for testing? Because currently, companies are telling employees, you cannot come to work unless you have a negative test from your doctor. And there's no reason for these people to even get tested. I'm going to share information about a patient that we had today at my practice, that the company is threatening to sue him if he doesn't get a test for the virus. Yes, Minister. They are threatening to sue him because we came to us yesterday, he had a travel history but no symptoms. We said, you don't meet the criteria, go home and isolate. Once you get symptoms, contact us. We will follow the protocol. We even gave him a letter to say, you don't meet the criteria, with our letterhead, the practice letterhead and everything. The company refused to accept this. I find that is unacceptable because it's putting a great strain on the healthcare system. It is frustrating doctors, it is frustrating the public. We need to inform businesses, you cannot test nilly-willy.
Thank you, Dr. Shandra. Dr. Shange.
Good afternoon, I'm Lady Shange. I'm the chair of the Health Policy Committee at SAMA. She has taken words out of my mouth. I just had two policy issues to bring out. The first one, then I won't waste time on it, was to say we need to develop a policy around what we are going to say is the message out there to the employers, because a lot of our GPs have been calling us and they've been asking in terms of saying, what do we do in this case? A lot of the employees are being turned away for two reasons. One, to have extended leave. So if a doctor has seen a patient and they've given them 2 or 3 days, they're being returned back to say, go and get 14 days sick leave from your doctor, and then come back with a letter that is stating that you are COVID-19 negative. But they are not really saying we're supposed to foot the bill for that test. So the second one, we also need to have maybe a modified policy issue around the rules of the HPCSA in terms of doctors doing virtual consultations. If we come to that, where doctors are not going to be able to do face-to-face consultations with their patients. But we currently have HPCSA rules and regulations which are prohibiting in terms of being able to do that. And we'd also like the medical aid schemes to be able to come into the party in terms of getting help for the GPs to be able to do the virtual consultations, because I think we're going to be able to move into that.
Thank you, Dr. Shank. Prof. Dai?
Thank you. Thank you, Minister. I think Dr. Shange has taken some of the words out of my mouth as well, because I think you asked, what can we do? What suggestions can we give? And I think the time has come for us to seriously consider telemedicine and virtual consultations. The problem at the moment is that the Health Professions Council guidelines on virtual consultations are really highly restricted. So what can we do? Perhaps from the Department of Health, we could have a directive which at minimum suspends these guidelines and regulations. But I think we need that to happen fast. Thank you.
Thank you. Dr. Notikita is the last.
No, thank you very much, Minister, and to everyone. I think for me, one of the most important things is how we communicate. As it is now, NICD is inundated with the calls. They wrote on their Twitter this morning that they've got another number. So my suggestion would be that much as the premiers of provinces have taken the position to create their command centers for COVID-19, it would assist if we can have dedicated COVID-19 call centers, so that we can curb that thing of people going into the health facilities and exposing everybody there. If we have that, then people know which number to call from which province. So it will be a provincial thing. So that's the first thing. The other thing which I have suggested even in my province is, let's consider patients, especially the ones who are at risk, the ones who have comorbidities, who come for their own medication in our OPDs. Our OPDs are jam-packed. They are a ticking time bomb. So let's consider giving them a 3-month supply of medication. And then we can see them as and when there's a need to see them. These are the patients we are talking about, Minister, who take taxis. Some of them, they get into what is called patient vehicle. And there are a group of people there. So if we can reduce that risk, they must stay at home, get their supply of medication, and as and when the need arises for them to consult, then they can receive. Thanks very much.
Thank you. Thank you for all those questions. I'll ask Dr. Patla to join the panel. I am hoping that we've been taking note of the questions that were raised, and we'll give this opportunity to the Minister and the Deputy Minister to respond to some of the questions that have been presented so far.
Okay, thanks, the facilitator. I'll kick off. Sure. I think indeed the issue of the readiness of our primary healthcare facilities and personnel, it's something which really is top of our concern, that we need to find very quick, urgent, intervention. And I think clearly this is an area where SAMA will be really very helpful. I mean, we, from the managerial side, from the political leadership and administrative, together with our colleagues in the provinces, we can work on possible approaches. But ultimately, a working solution can only be if it's also, have serious input from people who are in the coal face. There are a number of ways in which we could work around screening, appointments, but as you say, in most of township, rural areas, I know many of our clinics have already been trying to, especially for chronic patients, it's possible many of them have already started moving in terms of appointment systems. But notwithstanding that, you still find a lot of people who will be walk-ins, and it's those who are a threat to the practitioners and also to the other patients and to themselves. And of course, together with that, I think what we urgently need it's really just to agree on some kind of systems, work on, and it's not something which we can postpone. I think in the next coming days, so that when you talk about protective clothing, because clearly from practicality and cost, whether it's at the clinic or at the GP practice, we're going to have to find systems through which the Minister spoke of this patient zero. I mean, if we take that practical as an example, what could have been the precaution? We need to look at practical examples and then work back to that, and then to find workable ways in which, for instance, if there was, because now, I mean, by that time we spoke about corona as something in Wuhan, and just something we are theoretically preparing. But once that, now we're talking about rising numbers. Could we, with the clinicians, yourselves, and the practitioners, can we come with urgently, even if we can improve with time, guidelines to clinics, the front line, clinics, outpatient departments in district hospitals, GP practices. These are the guidelines. Whether somebody with basic protective, gear somewhere in the front, if a patient has got fever, has got some sneezing and cough, already redirected, and so that the whole system then kicks in. We don't have that currently, and that's why I'm saying, so that then, depending on what is the possible severity, then even the level of protection of the practitioner improves, but there has been some kind of screening. So I'm of the view that this is something which all of us, and what the minister spoke about of the clinicians group, I think as we try to finalize that, this is one of the key things which we would want to, definite proposals on, protocols, standard operating procedures, what are the basics, and what kind of protection therefore needs, and triaging needs to then kick in there. Now the issue of testing, one on demand and also the employers. I wasn't aware about this employer demand.
Huge problem. Huge problem.
Yeah. No. Well, I think this one, I'm not sure to what extent most of this would also belong to, because there are various business associations in the country. You've got the BBC, the Black Business Council, you've got BUSA, you've got also trade-specific associations, your steel and engineering association, retailers, and so on. I think this one, I believe that we are going to have to maybe play a central role in getting more information from the ground, so that we can also get the trends in terms of whether there is a trend of a particular industrial category, or it's across.
Yeah. It's across the line.
So possibly working with our colleagues in trade and industry, we're going to have to come with a very clear message, because this is totally uninformed and very opportunistic. Very opportunistic, because it then has a threat of totally clogging our systems, derailing. I mean, a campaign which needs very clear focus, because as it has been mentioned, the information from the people, the specialists in this field at this stage is that it's actually not helpful to do a laboratory test even on a contact who has not shown any of the 3 or 4 symptoms. You almost certain that you're going to get a negative. I mean, I think the minister gave you an example. Maybe because we talked to so many constituents, maybe it might not have been here. I mean, where we had to manage a particular social problem in one of our provinces in Limpopo, where we have a quarantine center, where the MEC was under pressure because there were students who had been on a course through one of the cities in China. And they were not in Wuhan, they were not in the area which had the epidemic, but because the word around was if you come from China, you probably have a coronavirus. So when they arrived in Limpopo and there was no quarantine, they were not tested, except the normal of arrivals at airport of temperature, and because they didn't have any fever, they were let go to go home. And they made a big noise to say, we are from China, and this province doesn't care about us. We have not been tested, we have not have been taken to the laboratory, we have not been quarantined, maybe we are infecting our families. And despite all the clinical explanations, we realized that it was now complicating very important project of the quarantine of the 121 who were coming from Wuhan, and juxtaposing to say those ones are favored, and we also come from China, and therefore it means there is favoritism in terms of who's quarantined, who's tested. And to then just lay the matter to rest, we agreed with the MEC that get those, because it's not a big number, about 16 of them, arrange with the NICD and the National Laboratory Service to get them swabs taken to laboratory. We knew that from, the standard procedures, they are going to be negative, but we needed to prove that. And it was done, the results came negative, and now the matter is closed. But that was really just to manage. But we can't carry on with that now with employers. So I'm just saying that we're probably going to have to work with our colleagues in trade and industry to send a very strong message that this is not acceptable through the various business associations, industrial associations, and so on, and really to plead with them. I mean, in the other structure which we work through, which is called NEDLEC, we have all these sectors represented. I was there on Monday. There's a delegation which represents business, and it's a matter which you're going to have to take through to the NEDLEC structure as well, but use other procedures, because this have a risk of totally clogging and derailing the whole system. I think a number of people had raised that. Maybe let me stop there, Minister. Maybe you can just check all the others.
Thank you very much. Can I just quickly go through some of them? Largely, we're saying the same thing with TM. So the first one that you raised about how to strengthen primary health care and provision of protective clothing. What I've done, I've got a WHO guideline, talks about rational use of personal protective equipment for coronavirus disease. So I've sent the whole thing, pamphlets, 6 pages to the president the chairman of SAMA, and therefore I request that it must all be circulated to all SAMA members just for easy guidance, because that at least is where we'll get the information from. We take it from WHO and that's what we use. So we're going to send that, and I'm going to ask that also that it must be sent to all hospitals and make sure that all those who lead institutions have got it. So it basically talks about certain minimum basic protective wear, mask and gloves. Largely, that's what really becomes very helpful. You don't need to put the whole costume and the hood and the goggles and so on, except if you are dealing with a patient who is in isolation. And therefore you walk out of your clothes, you get onto these clothes, you deal with the patient, you drop these clothes, you walk out, and then you take off your clothes, you take on your clothes. So that approach is that you could deal with it like this. And it should not be difficult. I think we just need to make sure that everybody catches up to it as soon as possible. But I think the one last thing we want to see is a doctor who's compromised by one patient now, and then tomorrow he is not available. We want the doctors to be available all the time, so we need to then focus on this approach. Maybe we should standardize it, but it's really up to the doctor to assess their own situation, because you are an independent professional, you make your judgment, we can't force anything, but we think that is a recommendation that should be able to guide you. So that will be made available. If there is any other way, I'm sure with this given to the chairman of SAMA, every one of us should be able to get it. One problem with this outbreak is that we must avoid getting stigmatized. And this problem of the employees is actually stigmatizing people, because if you didn't come back with a certificate from a doctor, then all the other workers are going to say, we are not going to sit with you, because you are now, you don't have the certificate. Now, it is nowhere in any of our guidelines that you must actually get such a certificate. This thing is new, as much as we've picked it up quite quickly. But right now we've tested just over 100 people. It's a big number for the impact of the outbreak, but doesn't mean each and every one of us has got it. And therefore, the approach that they are using is going to cause a lot more confusion. We're going to have to pick it up with NetLeg, with BUSA, and actually say, in fact, offline here, we're going to ask for the specific individual, so that we must just address them. Ignorance can be more dangerous. Ignorance, fear, anger is more dangerous than the virus itself. Now, we can't allow anyone to run away with that kind of position, because it means they're very nervous. Now, we need to make sure that they understand they don't have to be so nervous as to destroy people's lives. And therefore, we need to actually talk about it. There is a risk somebody could be having the infection, but really, we have an approach of how we deal with it. At the moment, we say we're following symptoms, but we want to widen it so that we can actually, get ahead of the outbreak. So we will do that with time. But I think the approach is important. Again, the question, who pays? Now, if you want to demand this, you're gonna have to pay for it. But if we think there's a need, there's no need for you to pay, because that's a proper indication. Where we will be creating possibilities, I think with time, we're going to have to increase broaden the criteria. I read an article in one of the journals that talked about how in the town of Venice, they actually got away. It was one of the areas which was almost turning to be an epicenter in Italy. They actually went on a wall-to-wall testing of people. It's not something that we want to do in the whole country of 60 million, but they did it in that area, and they were able to get around to come to actually push down the spread, the rapid spread. Whether in fact it was all because of the fact that they found out who was positive, but the fact that people got directly involved, it meant that even their behavior started changing. So those are some of the things that become quite important. Yeah, you are raising the issue of virtual consultation. It's in the guidelines of WHO. HPCSA doesn't quite agree with that yet. So let's leave it as an issue that we flag. Let's go into a conversation. I won't be in a position that we can sit here and start lambasting HPCSA, you know, they might just take away our licenses, you know. You know, so you don't have to be disciplined by HPCSA. But we are registered, by the way. Don't think we. So it's a real threat. Eh? So, but the reality is that we need to discuss. We need to discuss this issue and say, in fact, it's in the interest of public safety now. You know, it's actually, but also, you know, we need to move with time a little bit. You know, I mean, the things are there. You know, because in some of the places, telemedicine works. You know, in optometry, one of the most useful diagnostic tools is this one, where you have a clinic 800 kilometers away. Somebody sits there, they take a photo, and so on, and the consultant is sitting very far, and they make a diagnosis and you treat the patient from a distance. I mean, it works. We all know. Just that now we need to, you know, find a way. How do we get around, you know, this issue? But it's in the guidelines. You will see it. So we'll use the guidelines. Say, you know, WHO says we can use this thing now. May we? You know, then we'll have to start the conversation there. So I think that we note the point, particularly urgent because of the fact that some of the people could in fact be able to give you a better guidance to their condition, and you can talk to them on the phone and guide them, and then they don't need to increase the problem. I think Professor Adai, we hear you, and Dr. Shange, we hear you, so we'll watch and see how we can take it forward. Dr. Nutigita, you are quite right. You know, NICD told us that their call center, at one point they registered 103,000 calls in a day. Now they say some of them are pranks. And when people are phoning and say, yeah, we just wanted to know if it works. And then you got lots of journalists who phone, and then they want to come back and put on the subtext there, the phone, the call, the toll-free number is not working. It has happened. So the issue is that there's a lot of panic, and people do want to know. So people are actually flooding because of that. We just need to keep extending it. I think we're going to have to find some additional technology that will help us to be able to reach out to more people. So your proposals are quite acceptable. This one of patients with comorbidities, we're already working on it. One of the programs that we've agreed with PEPFAR is around 6 months, dispensing for 6 months. We've said we'll take the first 3 months and then do a quick feasibility study and then extend it. And then we are also doing what we call CCMDD, where we actually virtually get the medication to a clinic, and the patient only just walks into the place to collect the medication and go away. Right to Care is also piloting the kiosks, where you get a kiosk like a post office. You get a cell phone that and a message that tells you your medicines are ready. Go to such and such a kiosk number, so and so. Here is your PIN number. You go put your PIN number there, and then it opens up. You can get this stuff. We need to accelerate on those so that we can actually reduce the people who are coming to decongest our hospital. So we accept your point, and we are actually believe it's one of the things that we need to do now with speed because of the need to reduce the people who are coming to hospital for treatment. We could take another batch of questions. I think we kind of dealt with most of this.
Thank you so much, Minister. We received a number of questions during the day, and we're probably not going to be able to go through all of them. We're quite heartened as some with the response that we have received from the doctors that are serving the South African population. So I'll take a few of them. It's a sample of those that we received, and we want to just highlight to the colleague that sent those questions. It is a sample. Their questions were noted, and those would be
Can we take another round? Can we take another round from the people here as well?
No. Let me just go through. Yes. Okay. So I'll take it as I said, like, a few of those questions and give the minister and the deputy minister to respond. One of those comes from Dr. Michelle Broom. She's a senior clinical researcher at VETS. And I think it probably highlights some of the issues that were raised about the issue of communication. The question reads, can the health professionals be regularly updated on a number of new cases of coronavirus? At the moment, information is erratic, and thus there is no clear indication of the new cases on a day-to-day basis. So the proposal that they are putting on the table is, could you have an update at a certain time each morning? And I guess it's probably logistics. The minister will respond to that. The second one relates to this testing kit. They are wondering if we'll be able to come up with the testing as the number of cases increases in the country. So just the model or a process basically where testing will be done. They've noted here that in Italy 3,000 new cases per day are done, and the question is, what is the capacity that we have in the country? The second question, I think we wanted to address it as it is a bread and butter issue for our doctors on the ground. It comes from Dr. Romana Muhammad, and she's saying that if she were pregnant in the workplace, what safety precautions must she take, and is there any limitations in terms of the work that she should be doing? The next question I'll take comes from Dr. Sugan Naidu. Has provided a number of questions, but I probably will just focus on the following. It relates to a patient that has visited a practice, and they are asking for an update on the NICD screening protocols. As read, what are the steps to follow for a healthcare worker post-consulting an asymptomatic patient, but who becomes symptomatic, a few days later? What are the actions retrospectively and prospectively, I think, as you suggest to the patient that they need to have to be tested, that are required to be followed? So just, in granular terms, what does a doctor do when the patient comes in, gets tested, is positive? What is it that they need to do for the practice? Absolutely.
You got the question.
Okay. And probably then the last one, I think it's addressed, but I would just want to express it in the words of our participants online. Comes from Dr. Robler, and the question is, recommendations include full body protective gear. These are in short supply. It is recommended that the policy be updated, and can the government supply protective gear to practitioners? I guess the question here is that possible? There's a whole lot of questions, colleagues, that I could be taking, but in the interest of time, I'll stop here.
I want you there. Thank you.
Maybe let me just start at the end. I think the issue of protective gear has been dealt with in terms of the guidelines, in the sense that it's not an indication in terms of the front line to actually, go into the practice with the full body protective gear. And that's why I think we spoke about it earlier in terms of the fact that there are guidelines, and also what would be of use is just an organized kind of triaging, which make sure that the practitioner, whether it's a nurse or a doctor, there is a way in which, where there is a high risk. Of course, currently, because we've been largely dealing with imported infections, we're a little bit on the better side in that, as part of the history you would consider a traveling history or a contact, especially if you're able to upfront be aware that the patient is presenting with symptoms which, have a possibility of flu-like symptoms. But one would also maybe at this stage, with the manner in which we are going, maybe even venture into saying, I think it would not be regarded as being, exaggerating or hysterical to say anybody in the current situation in the front line, at the clinic, at the GP practice, the basic protection which I see Dr. Mabasa is already practicing, should be a standard, and Dr. Tandy next to her, Dr. Bali is also already having that. So I would, because that's really the first line protection in terms of the droplets and the gloves, and unless if, I know that in the normal practice, and by that time you would have excluded those risks if you really want to use your bare hand in some of the palpations and so on. But by that time you would have known the history and you would know that it's safe. So I would actually at this stage venture to say that we should actually, as not necessarily that one is closing the discussion, but as we agree that there should be more formal guidelines going in line with the WHO, but definitely it's only when we're moving into a more intensive isolation and that area when we now speak of full gear. That's really my understanding in terms of that particular question. The question of Dr. Sugen Naidu of an asymptomatic patient, essentially, I think in our earlier discussion, we sort of addressed that. If what is now in the literature, in the experience of clinicians and researchers is correct, it would mean that this doctor, the chances of actually acquiring the infection would be very low, because the literature and the research and the clinical reports at this stage indicate that in the phase of in the asymptomatic phase, the virus is not being shared. It doesn't mean that, like all of us know that these are issues of trends, but it can never be 100%. So in my view, largely we would expect that he would have been safe because it was still in the asymptomatic phase. But it would be a kind of a scenario where one would be very sympathetic to, once it's detected that the patient has subsequently become symptomatic, for the doctor actually to move into also being laboratory, taken a swab and actually checked in the laboratory. A few days down the line after having gone the information, because considering also that it could be still in incubation, it could even be done if maybe more than once. I mean, you look at the incubation phase. Once you get the results of the patient, that the patient is positive, you could do the test. If it's negative, maybe another 14 days, considering incubation. I think it would just be a safety measure. That's my view in terms of. But clearly, this is a kind of scenario which is going to be quite common when you consider the issue of the incubation period. I think let me leave at those two.
Just pass the closer. Before SAPC think we are marginalizing them. I don't know the difference between the two. But you might be tempted to get into the internal politics. So, thank you very much. The last question is about, can the government provide doctors with protective clothing? Look, I think that's not create false expectations. It's not going to be possible for government to provide private doctors with protective clothing. It's unaffordable, it's difficult. Yes, in the public sector, we still got to also decide which is the area where you need to start. But because everyone is in business, I think what maybe we need to be talking between ourselves and SAMA is that maybe we form a delegation to the manufacturers of this thing and ask them for half price or less than that. I'm not sure whether it's possible, but certainly I would be prepared to be part of that discussion, you know, because we're not out here for business. We are trying to save lives, and we're dealing with an outbreak, and the prices can't be the barrier before we can actually solve the problems. So I think let's talk about it that way. I don't think that government can actually promise, we'll give you all free masks and free gloves. It's not going to be that easy. Yeah. However, I think the point is valid. How do we get them? Because they are short supply and so on. That's why I'm saying let's make it a concerted effort. Amongst the regulations that we actually have been that were released by the ministers today, we had quite a bit of a discussion with Minister Patel of DTI. And one of the issues is that we have to deal with the issue of allowing industries to coordinate and kind of collude insofar as what it will take to actually increase the stocks for South Africa. Not to collude and raise the prices, but if they want to collude, they must collude to drop the prices. But even then, it must be prices where even the department is involved, so that they can't collude and put prices where government can't even afford to source the stuff. So the approach is going to be, yes, let's go and approach them. If they've got the stuff, give us at a lower price, because here we actually have to make sure that each and every doctor, wherever they actually are protected. So let's go and deal with it. I think that's one approach we should be able to follow. I'm ready to assist there, and we'll come together, and see and start the negotiation. Then a very valid point from okay, let me deal with the NICD protocols. It's a very interesting issue. I think the first issue is that what do you do if your patient is asymptomatic? You test the patient, and a few days later your patient turns out to be positive. Now, it's a very interesting clinical evolution of the disease. The bulk of the people by right will tend to be able to emit the virus only on the basis that they have got symptoms, and that's what happens. But it is also said that about 24 hours before the virus is emitted, some patients may be asymptomatic, and then 24 hours later only they turn positive, but they already started emitting the virus. It's a question of how the virus evolves, but we could only imagine or assume that when that happens, it's unlikely that the dosage, the amounts of virus are too huge enough to be to prejudice someone severely at that kind of level. However, if the patient was negative, it means the patient was asymptomatic. The bulk of the people who are here, who are tested, who came from abroad, they largely came back asymptomatic. That's why we couldn't pick up their fever at the airport. And then the approach is, even if you did the test, you would probably not have found them positive at that time. So should we test them all It's still a debate. When we are together, we make a lot of noise about that debate. You must also get involved in that debate, because you'll read, and then one day we'll have a better answer. But for now, it's a very interesting area of debate. However, the guidelines are no symptoms, no testing. Then when you've got symptoms, then we test. But then in the process of someone turning to be positive, that's, I think, you can then go back in retrospect and count the doctor as a contact of the person who has subsequently become positive, and then check. Even with the contacts, they don't classify them as of equal risk. There would be a priority risk, there'll be intermediate, and then some kind of peripheral risk. So when we sit here and someone has got symptoms, those who are spending more than 15 minutes within 1 meter, then of course are highest risk. So family and those who are working very closely would be high risk. And then there are those who may not be immediate risk because they were in the vicinity. But there's by no stretch of imagination can somebody cough and throw a droplet 200 feet away, and then someone is at risk. It's unlikely to happen. So what we're then saying is that the approach we take is that let's just deal with the obvious, and therefore try and manage the process that way. So you'll have a class where the people are sitting together in a small discussion group, they're talking together, then there are others who are part of the class, but they are sitting at the back of the class. Then it's fine. But there were those who were with them together in the hall, in the dining hall. They were seated that far. Oh, now I was in the same hall when somebody, but he was far. So you are very low risk, so we just keep you in mind, but we don't worry you. We worry about those who are nearby. So the approach, therefore, is to try and triage the level of risk and therefore assess you on that basis. So I would then say that pretty much the guidance that we're following is that. So we would be guided by additional literature to see what else needs to be done. The only reason why myself and Deputy Minister, we actually favor this thing of surveillance testing, where you just go into a place and look around and say, yeah, we're going to test. The reason is not because there is any indicator, but the problem is that you just want to check because of the fact that some of the symptoms can be very mild, and yet people are in a very vulnerable area, high congestion, settlement and transport and poor immunity, high poverty levels. You want to check if we aren't missing anything. So you could go into that area and pick up those who might be having very slight symptoms and see whether, in fact, we're not dealing with this problem. If we find no one, well, of course, that's very nice, because then we know. In some of the areas, I think we should want to do that. So that's the approach that that we would generally take. Then, Ramona, what safety precautions if we are pregnant? To be honest, we don't know. So what we will have to do is we'll have to actually talk to some of our colleagues at NICD and just get them to comment on that, and we'll bring the answer back to you. We will talk to our other clinicians in NICD and see if they've got that. We don't have anything special except that in generic terms, pregnancy, diabetes, HIV, other underlying diseases, chronic obstructive airway disease, neoplasm, chemotherapy, radiotherapy, all those things would predispose the individual to, easier attack by a viral opportunistic infection. We can just leave it in general terms. But when you want to ask specifically, I think someone must tell us if they found some research that they can guide us. So we'll ask them to give us that answer. I think it's an interesting question. I'm interested in the answer myself. That means that in future we can answer if somebody were to ask us the question. Then the question of what is the capacity for testing? Well, I'm going to read a message, because the CEO of NHLS, Dr. Kemicheti, I asked her the same question during the day, because other people asked me the same question. So if it doesn't make sense to you, don't worry, but I will just say, don't worry. I can just say we will ask her to answer to Sama, so I asked her the question. I asked her, what is the current testing capacity and when do we increase this capacity? Okay. Then she says, well, right now we have a capacity to do 5,000 tests per day. From Tuesday, we'll be able to do 15,000 per day. By mid-April, we'll be able to do 30,000 per day. Limiting factors are reagents. Next week, we're getting 20,000 kits for the tests. Suppliers, they promised that they will have a special production line for us, but planes are being turned away, so we have to negotiate it from there again. Now, we discussed this issue as well because everyone said, yeah, good lockdown, stop the flights and so on, but they're bringing supplies as well. So those are some of the contradictions that we must face. It will be something that we have to deal with on a continuous basis. So that's the answer. If you want further questions, Dr. Kemi Chetty's line will be available to the chairman of SAMA. Then the other question was a regular update. Now, I think on behalf of our team, okay, let's start with the first issue. The figures of coronavirus throughout the world are monitored through Coronavirus Worldometer. So please write that down, those who haven't been using it. Worldometer, it updates. So each time we put something out on the media, it will show. So it's almost as accurate as anything. I found it very reliable, and it actually gives you a better sense of things that are happening. Now, we will try to update regularly. But let me just be upfront and tell you what kind of things happened behind the scenes. At some point when the private laboratories were doing the tests, there was a need for the test to be validated by the National Health Laboratory Services. Whilst that happened, the patient might know and tweet about it, but we are not ready because it's still going to be validated. So then it delays the time by which we can release the results. Then sometimes, as of late, we have now said, okay, we're going to draw a line, 2000 at night, then we'll get the last reading, and then we'll get to look at them. When they give us the results, there are a number of areas which we know the public will be interested in. Certainly the reporters might want to ask. It's very difficult to say, you can actually say, one more person was positive. The media is going to ask you, and the public wants to know, which province is that? What is the age? What is the gender? Was this person coming from abroad, or was he an internal transmission? So some of those questions become a bit of a challenge, because then when you don't have all of that information, then we then delay and say, no, you can't. So someone is expecting that we must update at 8 o'clock, we can't, because we're still waiting for the information. If we don't, we'll go out with information that's incomplete. And now anyone who's listening will say, but why can't they answer such a simple question? I mean, the patient has some age, why didn't you tell us? It sounds like we are hiding something. So in the interest of transparency, we delay and try and clarify. And it's not just as simple. You get other instances. So for example, one of the people that we tested is a child, 3-year-old. Child is coronavirus positive. And then you say, okay, but did the child travel from somewhere? No, it didn't. And so what happened? Did the parents travel? No, they didn't. Okay, did you test the mother? Actually, we tested the mother. Mother is negative. Then, and the mother said, I think so-and-so was positive, and he was my friend. And so now, okay, wait, try and check if you can find so-and-so that was positive. Time lapses. And by the time you come back, we now have to start speculating about the mother. Could it be that the mother, that the source of the infection is not in the family, it's in the crèche? Now you go and check, now we have to try and say, okay, let's round up the crèche and so on. By that time, all the parents are upset because, where the children are are exposed to this one. So I have to now, okay, wait, we'll do that, but you can't answer the question yet. But is it possible that the mother was actually infected and was positive and turned negative in the process, and then the baby is the one that's lacking because it's immunocompromised? You understand? Those discussions become very interesting clinical discussions, but then they will delay by the time by which you get the results out. If you say that this child was positive, we want to know who was the contact. Then they say, no, we found out that the parents actually had come from Portugal, they came back. Okay, that one is sorted. All right. Then this one, we can't find who was positive. Now, you say to me, where has this person traveled to? So we traveled to DRC. DRC has got 7 cases today. We got 150. Now, it's us who could send a person to DRC who got a thing, not DRC giving to us. Is that possible? Yes, maybe not. But maybe this DRC person didn't actually come from DRC. It's not DRC. They must have come from Belgium. They must have gone to UK or something. Can you check that? Then whilst we're clearing that information, time goes. Then they say, hey, why don't you get updates? So with time, because we are early on, we have been very particular to try and counter fake news and disinformation by ensuring that we get correct information first before we release. There will come a time when it will not matter, because the numbers may be high, and therefore all that is important is just to give the figure out there, and we won't be analyzing anyone. You've seen people have come from different parts of the world, so if there's one more from there, does it matter? And if you've got internal transmission, if you found one more, does it matter? What counts now is what are we doing to stop it? So that time, we will not be worrying about the details of the kind of nature that we're dealing with. Even at that time, fake news or no fake news won't even matter, because we'll be talking about, everyone knows these are the numbers we're dealing with. If it's 1 or 2, there's a story you can't account for, it's neither here nor there. The point is therefore that because it's early on, we're catching up this kind of problem. So having said so, we then also decided to put up on our own website, and I'm going to give you this one because I'd like you to have a look at it. It's called www.sacoronavirus.co.za. Now, all small words, and if you press on that, we're trying to create a stable database, a stable website where you can find as much information about our coronavirus. There's not much yet. It's just that we've taken the issue up very quickly. There's not a lot of things yet. But what you will see when you open that site, it will look like this. It looks like that. So if you press on those dots, it shows you some more information, symptoms. Don't panic, and then it gives you what you should be, how you should approach it. It goes on to show you preventative steps, shows you the micro appearance of the virus, and it gives you some of the stories, and then begins to give you figures. How many tests have been done? 4,832 COVID-19 tests have been done in South Africa. How many are positive? 150 are positive, and we update this every 24 hours. So you will always go to that site and find the information. You don't have to wait for a statement. The statement is ready to help the journalists because they write the stories. They also want to balance up with the stories that are coming out from somewhere. Then how many cases are negative? 4,682. How many deaths? 0. And then from now on, you're going to start recoveries. We're going to show you how many have recovered. And so that's how we're going to be dealing with it. The issue of recovery, and again, it's more interesting for you doctors because it's an interesting debate. When do you say someone has recovered? Clinically or serologically or just by law of average? You see? So now, and I'm saying this because it's a debate that we've had. Now, the easiest diagnosis, if you were testing positive, now you are testing negative, we know that you no longer are infected. You may therefore have recovered from the virus. To what extent you can recover from the virus and still suffer from the underlying concomitant disease and therefore not fit for discharge is another issue. Are you recovered? You don't have the virus, but you're still in bed. Are you recovered? So it becomes an interesting debate. That's really more for the clinicians, you see. So the next aspect is basic recovery is a clinical appearance and lack of symptoms. Disappearance of symptoms. You had symptoms, you no longer have symptoms. That's very nice. Now, patient number 2 never even had symptoms in the first instance, but she was positive. Did she recover? She spent about, maybe 10 days still positive. What do you say to that one? She has no symptoms. Has she recovered? Now, okay, then the others, like the husband there, had symptoms, and when we tried to admit him, he says, I'm healthier now than I was 2 days ago. In other words, clinically improved. Now, clinical improvement is recovery. But clinical improvement with a positive COVID-19 test, is it recovery? Yeah, it is, but you're still infective, okay? But you're improved. So there's a debate, because what then becomes a problem? Others say, well, the patient went to the private doctor and paid 1,200 to get the test done. The patient is not prepared to pay another 1,200. So are we going to force the patient to go back? No, you won't. So what are we going to say? Have you still got symptoms? And the patient says no. Has he recovered? We don't know. But yes, he has recovered. So the question then becomes, do you want to use a law of average to say 14 days the viral shedding is complete? And therefore you say, okay, 14 days is gone, no symptoms. So we assume that he has recovered, clinically recovered. The question then is, what if, because the 14 days viral shedding is actually an average. So patient 1 could shed viruses out by day 10 and recover. But patient 2 might shed the virus out by day 14 and recover. But patient 3 might shed the virus by day 17 and recover a few days after. So what do you say? One of the patients, that was the first patient, the wife had recovered negative, but the husband is not. Well, the husband has improved. He's ready to go home. But the problem is he was still positive. They're still going to be tested. So that is a debate for the clinicians. As a result then, what we have then said is that clinically, the doctor will tell us if the patient has recovered. Then we will take that the doctor said the patient has recovered. Then we will say, in terms of the average, at 14 days, we must find a mechanism to make sure that the patient is tested, even if he can't afford to go back to the same doctor or to the laboratory, private laboratory. That is why I raised the issue of an NGO that will do the mop-up. You have the patient who has clinically recovered and is responsible enough to be kept at home, and you can send him home as long as he's not going to infect any other person. But at the same time, you've got 14 days finished, but you can't be sure whether this one will take 17 days or 19 days or 14 days or 10 days. Therefore, there must be a team that will go and follow patient one by one and take the swabs afterwards and then test and then give us the result. Which means what we are requesting from SAMA. You may find later that someone is going to call you as a doctor and say, Dr. Mkhize, we are going to see patient so-and-so. How was so-and-so? And then you say, he has recovered, I left him to go home. They say, we would want to go and take a specimen. Please be aware, could you notify your patient that we want to go and take the specimen from him? We're coming from such and such NDO, we're working under NICD, so that we can close this mystery of what clinical recovery means. So it's an interesting discussion, which I think with your experience as you sit there, you're going to give us information and guidance. What are you seeing? Because after many patients, we may not have enough people to go around and test all the 20,000 patients, but we might then rely on the general experience of general practitioners that by day 14, 75 or 80% of their patients would have shared the virus. So we can take a chance on that one, because as long as it's not going to infect someone, then we can actually say, just watch out for the next few days, you'll be fine. By then we know many people would have anyway come across a coronavirus. And therefore, we think the chances are not so bad, and so on and so on. You also don't want to clog the bet with someone who says, I'm well. It's just that you don't know about the test when they're going to be positive. So it's an issue of clinical recovery. It's a department for, it's a debate for clinicians. That's just for me an angle of interest, really, which as we go along. Your discussion is going to actually end up shaping us to change policy because of the experience that you'll get. When you come back and say, I don't go that route, this is what we always see. Because that's what normally would happen. You get your experience, and then we use that experience to actually inform policy in that direction. So that, for us, would be the one thing that would be of interest. But thank you very much. The questions, and still feel free to send us the information so that what proposals you have, we can work on the basis of those proposals.
Thank you so much, Deputy Minister. Thank you so much, Minister. We still have got lots and lots of questions. We will take these, categorize them in terms of the major topics that have been raised. I think what is very clear from the engagement tonight is that we probably would like, and we will ask the Minister to indulge, someone once again, possibly, to come back as the situation unfolds, if other questions come up, and how do we work together as the public and the private sector to deal with the issue. I'm going to apologize to the colleagues that are online. We've received the questions, but in the interest of time, I think we probably will be letting those go. I saw 2 hands. May I just... Okay. Short?
Is it me?
Is Prof?
Mr. Public health physician. Just anecdotally, as our numbers are going up, our number of websites and hotlines are also going up. So I think some can play a definite role here, because I think what the epidemic curve will move now, it will be more ambiguous case. And I think we will get more and more these type of cases which doesn't fit into clear descriptions. My second question, Minister, and I think it's just a comment based on my colleagues from Italy and other countries, where we are going to say, and I'm really listening, and you are depth into that about the shedding and the window periods, how long it will go. I think they are looking into us for 2 things. One is the HIV. We really don't know the link between the HIV and this virus and the diabetes. And I think this lethal cocktail, what we have. And I think we need to be very careful, and I'm really intrigued that you have thorough insight into this, and we really need to understand this process. And you mentioned about the window period. I think that false negatives, that case which you mentioned, somebody just arrived from Italy will not be positive. And I think we need to make it very, very clear from our side. And my last comment, you mentioned about you are setting up various groups, and one of them is epidemiology and surveillance groups. And I think, Minister, please consider the family physician and public health physicians, because we are the key group that which are on the ground. And within the summer, I think we have these groups, and we really need to support. Otherwise, this is not going to work. It's just going to be something. Thank you.
Thank you very much. Not only that, words have been taken out of my mouth by all the speakers, including the last one, which have said. I think that this is, I like the fact that it has been mentioned, this is one of the bad flus that we had. And we must look at it that way. This is a bad flu, and we are in a war situation. And in a situation like that, Minister, we should not be threatened by any form of deregistration by any institution, including HBCs. That's one thing. Second thing is that, and it has been dealt with, is the question of the cost. Many people who are traveling and are covered by their private health insurance, traveling insurances, and people are inside the country and do not have that kind of luxury. I think it's important, but it's been dealt with on how to deal with the cost. You've got a political capital, Minister. You've mentioned it, and I think it's a good, you must be feeling very good about it, that all political parties are supporting you in this fight, in this war. I think use that political capital, use it for the purposes of making sure that we've got the laws, and we've been reminded now that many of the laws and regulations that we have, we actually have been sitting idle, not using them. And now that self-quarantine, you can force people to self-quarantine. Those laws and regulations have been there. Make use of them, especially now that you have got that political capital. Lastly, Chairperson, and I think you have been having very easy questions so far. In a war kind of a situation, you cannot face a war from many different fronts. Our borders are very porous. I hear what you're saying, and I think something has to be dealt with even at the interministerial committee level. What inside Norgo, also our borders are very porous, and we're just simply going to be having this war. Thanks for that. Thank you.
Okay. No, thank you very much. We accept the issue of the borders, although the way this disease so far has evolved, you're really not likely to get someone who's going to walk across the border on foot who would have got the infection from anywhere outside the continent, because right now the numbers of countries have gone up to 29 in the continent, but really the infection is not as rife in the continent. I think we are number 2 from Egypt. Egypt is about 220. We're probably going to be matching them in the next few days, but that's really the highest number. So I think we must not so much think that the neighboring countries pose a serious danger of giving us the virus. We do pose that risk that people will move from here, because 21 million who land in the airport every year are actually landing in South Africa, in our Tambo, who come from all over the world where the disease is rife, and they're visiting everywhere in the southern Africa, where we've got all the wild game reserves and all the nice Vic Falls and all the things. So that's what's going to happen. So I think the borders, yes, are an issue. We've closed down a number of them, but still the villagers are really not a big threat on this one. And other diseases, you could say, yeah. The other issue you are raising about laws, in fact, we keep saying this, and people have not quite noticed that it's actually true. We say quarantine is voluntary. Please quarantine because we ask you to do that. But please don't refuse, because because the law is there to take you in, and if you don't refuse, it can be enforced. Now we have seen 2 days ago, it has been done. 12 o'clock midnight, the MEC went and applied. We'll use that everywhere, so we'll not have a problem with it. However, don't say there must be no threat of deregistration. We understand what you're trying to say. But the way you're saying it is that these laws we've put up, if somebody decides to profit here out of this, why shouldn't we deregister them? Because you are now getting really to put a lot of strain when we're trying to relieve everyone. That's why we're saying that this thing of stockpiling has to be done quite carefully, has to be actually outlawed. So that is the issue. Now, in this case, what it basically means is that we would say, let's work together so that where we collude or collaborate, we're basically doing for the best of the patient care. That's really what we are saying. And then we must then do the best that we may not have been able to use up to now to really enhance the care to the patients, like we're talking about the telemedicine issue. So that point is understandable. Now, but you are quite correct. We treat this as a war. There's no way we can run a campaign unless we treat this as a war. And that's why you hear the word command. Basically, look, we are very happy with your rights and debates and so on, but please, can we move on and implement stuff? That really is the message for us. And truly, it is a bad flu. It's a bad flu. It's just that it's new. Because it's a zoonotic phenomenon, our bodies are naive to this virus, so they are not able to respond as they would have responded to any other flu. But because it has killed so many people, everyone is very nervous about it. And that's why it's important for us to talk about it, to say it need not be as bad, but don't be complacent. And that's the message. And we can actually beat it, but we don't just sit there and do things as you normally do. We need to do something about it. And it's better if we all stand up when we still have to impose very light restrictions. than to be forced to say we're going to close down the place because it's an epicenter. And therefore, we really realize now that there's no other way. We have to actually protect the other regions from this particular region, the community in this region. So I think it's a message that we're trying to send to say, let's take it seriously, but we must not panic. You know, in a war situation, the fact that you have to face a formidable enemy or opponent does not mean that you must actually be so anxious that you are fearful, because you actually will not be able to focus. And therefore, it's important for us to say we need to be systematic, we need to be focused, we need to be committed, but we need to be courageous and bold. We're going to move forward, we're going to face the pain, but we must be able to make sure that ultimately we are the ones who will prevail. The interesting issues, what we'll do, Prof, is that family physicians should be part of the clinician society. And we'll need to just coordinate that, because we did discuss with the chairman of SAMA that we need to bring as many of the family physicians and general practitioners and the clinicians in managing, because the experience across all of that is a spectrum that's very, very helpful. So we would want to tighten that one up. But you have made a real, very important point. No country can actually give us as much information about the response of various individuals to an infection of this nature under the circumstances of HIV infection, concomitant tuberculosis, and so on. So the space and scope for new research, which will be world-class and leading the world on things that are more possible to do in South Africa, arises now. It offers a huge research opportunity that we can actually be leaders in the world in discovering new things about the conduct of concomitant viral infections, and probably even the management thereof, and the even possibly cross-reaction of the medication, antiretroviral for this one, what does it do to the other virus, and all of those issues. It will be very, very interesting. So I think it's an opportunity that we must really work on. Indeed, we will get ambiguous cases, because we've already come across those. One of the cases that was reported in Freiburg, person, they said was a weak positive. And we asked them, did you travel anywhere? They said, no, didn't travel. But then they said, but the husband travels a lot. So I said, but the husband travels a lot, but so what does it do to the patient? Now, we were not too sure whether that's a relevant point, you see. And as a result, it went for validation, came back negative, and we said, okay, now what do we say? Said, no, it's negative. But somebody could have gone back and said, under what circumstances do you get weak, positive, ambivalent results, and an indeterminate kind of test? It's an interesting area, because you might find that there are features which you'll pick up in South Africa which no other country can pick up. And these are the interesting trends that I think, as the researchers and clinicians in South Africa, whether virologists or various kind of research groups, you could look at a lot of these issues. And by the time we emerge from the COVID-19 virus, we'll actually be wiser for other things that were not intended, simply because we're just unfortunate to be an epicenter of various epidemics at the same time. It's a bad luck for us, but actually it's an opportunity to actually lead the world and lead medicine in discovering a lot of new things. So I would say, don't get so fearful. Let's go and venture into opportunities that are brought in by the fact that here is this feared infection. We're going to sit here, we've got no choice but to emerge victorious over that infection and the whole combination of them and fight them. In so doing, we're solving the things for ourselves, but we're providing the solutions for the world. And that, for me, is what we think we can do. And so don't fear. Let's go for it. We're saying we're in a battle. We're going to go on in a full fight. But when we get on the other side, we must emerge as heroes who have discovered things that are actually going to make the world look back and say, hey, thank you, South Africa. If COVID-19 didn't get to you with all your problems, we wouldn't be knowing all of these things which we have now learned, because we've got capacity, We've got the worst burden of disease, but we've got possibilities of resources, and we've got international partners and global collaborative partners who would be prepared to work with us. And we've got keen researchers who can actually grow into an extent that they can actually be top class, leaders in the world on various areas, not for anybody else, but for solving our own problem. And that way, the world will actually be getting good leadership. So from that point of view, I'd say very interesting issues. Let's hear what's happening in China, what's happening in this thing. This afternoon, there was a webinar where the WHO pulled a lot of experience from China. One day, it will be South Africans, researchers, clinicians, virologists, who will be sought after by the world to say, tell us what happened. And we'll be telling a story of people who combined at the level of ordinary community and clinicians and researchers, academics. They actually combine to create an unusual combination of solutions that takes us into a distance of dealing with this outbreak, that in future, if it comes out anywhere else, we use the solution from South Africa. And that's what I think we must actually focus on. Anyway, thank you very much. Interesting discussion. In future, we'll be ready to come back.
Thank you so much, Minister. I would now like to call upon our Vice Chairperson, Dr. Mzuka, for a vote of thanks and some closing remarks.
Thank you very much, Program Director, Honorable Minister Dr. Zweli, Honorable Deputy Minister Dr. John Parker. I would like to take this opportunity to thank you for the time that you've spent with us at the South African Medical Association, our members, and all those that are online. We really appreciate what you have done for us. As the association, we always want to welcome you and also thank you for
subscriptions.
for taking this time to be with us. And I would like to take this as a privilege for me to be handing over these gifts from the South African Medical Association, and really thank you for your time. Yeah, I'll bring the protocol.
We want to see what you
To be used.
No, definitely.
And thank you so much.
By members of SAM.
Members of the media, the chairperson of SAMA, the leadership of SAMA, the senior leadership of the Department of Health, all of our colleagues who are there at home and also online. We really want to thank you for this opportunity that you have engaged in this discussion. And I would like to thank our program director for being so professional in helping us with this. Thank you very much.
Thank you. Thank you. Thank you.